the Demography Today lecture series, sponsored by the BBA Foundation and organized in coordination with the Spanish National Research Council and LOMPOP European project. And we are very lucky today to have here Carol Jagger, who is AXA Professor of Epidemiology of Aeging at Newcastle University and the Deputy Director of the Newcastle University Insitute for Aeging. Her research program spans demography and epidemiology with a focus on mental and physical functioning in aging. She is the leading UK researcher on healthy life expectancy, has advised the Office for National Statistics and the Scottish Public Health Observatory of Healthy Life Expectancy, and has provided evidence to various government committees, including a review of trends in life and healthy life expectancy for the Government Office for Science for Aeging project. Carol has been involved in the design of analysis of most major UK cohort studies of aging, including the Medical Research Council Cognitive Function and Aging Studies and the Newcastle 85+ study. Her current studies include MODEM, comprehensive modeling of cost and outcomes of interventions with dementia, funded by the Economic and Social Research Council, linking spirituality and religiosity to health, life expectancy, and disability-free life expectancy, a global comparative study of older persons, and then PROMISE, prevention of malnutrition in senior subjects in the European Union. Carol is a chartered scientist, a fellow of the Royal Statistical Society and the Gerontological Society of America, and honorary fellow of the Institute and Faculty of Actuaries. And for us, it's a great pleasure that we managed that Carol could have some time to arrive here to Madrid. She has been very kind. Even last week, she was not able to get out from Scotland due to the snowstorm. So we managed to reschedule the lecture to this Monday, and she was kind enough to be here, even we have changed the data and so on.
So I'm going to talk to you about trends in healthy life expectancy, and I'm going to give you a little glimpse into the future, perhaps as well, from the MODEM study that Diego mentioned. And mostly, I'll talk about the three studies that Diego mentioned. So the big question that we all have is, we're living longer, are those extra years healthy ones? And that's the question that's on everybody's lips. And I'm going to have a look at how that plays out in European countries through the work I did for the Government Office of Science. Unfortunately, that didn't include Spain, but I'll say a little bit about Spain. So the UK, we're very lucky. It computes disability-free life expectancy and healthy life expectancy, and has done for a long time. And we've got very good data, and we've got regional data as well. You know, the EU computes healthy life years, healthy life expectancy based on self-rated health, and chronic morbidity-free life expectancy. Those are the three questions from the European module, but I'll only talk about healthy life years today. The big problem when we're looking at, are those extra years healthy ones, so if we're looking at trends over time, is that questions have changed over time. And that's true in the UK as well, annoyingly. But another big issue that we often forget is that institutions, people in institutions are often not included in those surveys. And if you're looking at change over time, and the health system is changing as it has done in the UK, so that now we're having fewer people going into residential care, and I'll say a bit about that. Then if you're looking at the trends over time, you don't get true trends if you miss out those people. So the plan is that I've got three sections to my talk. I'm going to look at the past trends in life expectancy and healthy life expectancy at different ages, because you get a different picture depending on which age you take. I'm going to look at that across the EU, for the UK and for other specific EU countries, because that's what I had to do for the trends paper. I'm then going to look at past trends in life and health expectancies from the cognitive function and ageing studies, and that's a very unique study because we used exactly the same measures of health, exactly the same design of the survey. It includes people in institutions, and we've got more health measures than just disability and healthy life expectancy. And then I'm going to take some results from the MODEM project. We've actually produced now trends in dependency-free life expectancy, but I can't tell you those because they're under review at the minute. So it's just a bit too early for those. So past trends in life expectancy and healthy life expectancy. This shows you life expectancy at birth for selected EU countries, women, full lines, men, dotted lines. They're different, but they're all going in the same direction. And pretty well, you know, we've all increased by around 2 years every decade for life expectancy at birth. Although we've all shown this remarkable little blip around 2012, which I notice that you have now gone back up to an increase, whereas we haven't. We seem to have stagnated in the UK. We can talk about that later. So death's easy. Life expectancy is easy. Death, unequivocal. Okay, we know when people die. But healthy life expectancy, health expectancy is less simple because we can measure health in a lot of different ways. And so defining what we mean by health, I will show, matters a lot as to whether we know whether those extra years are healthy ones. So there's a lot less harmonisation across countries. It's not perfect with mortality data, but within the EU it's probably pretty good. But with health, we've had to work very hard to get a single measure, the healthy life years, and we're still not there yet. There are still some countries who are not quite there, and it took the UK a long time to get to the right question. So there's less harmonisation across countries and within countries over time. And we need to look at the trends in health expectancy alongside the trends in life expectancy to be able to answer this question of whether life expectancy gains are bigger than health expectancy gains and there's an expansion of ill health, morbidity, disability, whatever you're looking at, or whether the health expectancy is tracking faster than the life expectancy, so there's a compression, which is what we'd all like. We'd all like the compression. I want to say a little bit, because some of you will be analysts, about data and analysis. Usually, when we're looking at trends, we use the Sullivan method, where in fact we just take a life table and apply the age-specific prevalence of the ill health measure, so it might be disability, to the capital LX, the years lived from a particular age. And therefore, we partition those years lived into years lived unhealthy and healthy, and reconstitute the life table, and then that's what we get. But if we've got longitudinal data, we can use multi-state life tables. And that's often been, in the past, we've thought of that as a sort of gold standard. Wouldn't it be wonderful if we all did longitudinal calculations? It has its plus and its minus points. It's not so good if we're looking at trends because of attrition. But what it can do is, with longitudinal data, we can separate out the underlying dynamics of the health expectancy, and we can say, are these differences due to differences in incidence of disability, or differences in recovery, or differences in survival with disability? Okay, so we can unpick any differences in, say, disability-free life expectancy. So that's very powerful. All of those measures are inherent in prevalence. Okay, prevalence is just the cross-section of, and the numbers that make up the prevalence are made up of incident cases and surviving cases. But you can't unpick them with cross-sectional data, whereas you can with longitudinal data. So it's not really an either-or, it's a what are you using it for? So cross-sectional methods are the easiest for trends, but often we have problems if we're looking at subgroups. So if we want to know whether there are differences in trends in healthy life expectancy by education, we often don't have the life tables by education. We certainly don't in the UK. You may have here, but we don't in the UK. We do have regional life tables. That's about the only other thing we can do is look at local areas within the UK, and I'll say something about that. But we have to fiddle about and do other sorts of calculations to try and get life tables by social class or by education, or by ethnic group is the other one that we've been quite interested in because of the large minority ethnic groups that we have in the UK. Now, those are not a problem with longitudinal data because the mortality is inherent in the study, and so you can get healthy life, disability-free life expectancy or estimates by subgroups. And I've done some work on with education with that too. So let's think about Europe. This is not, I think there's one more year now, there's 2014, but this graph is from the EuroHex website and shows you life expectancy in blue and disability-free life expectancy in red and green, and I'll say the difference in that. For the 15 countries of the original 15 countries of the EU, I do not wish to talk about Brexit tonight particularly. So I'm still considering that we're part of Europe, and I'd really like us to stay that way. And you can see so the bottom lines, the red line is the old European Community Household Panel, which provided the original data for disability. And then the green lines are the EU Silk, which now produced it. So that's the healthy life years. So I've done it for the 15 member states because we have this earlier data for them. And you can see life expectancy is increasing and disability-free life expectancy is not. It's pretty stagnant. And so the extra years of life are not healthy ones. The extra years of life are years with disability. Of course, inherent in that is that there's quite a lot of variability within the countries. And if we look at that, so the top lines now, this is for men, the top lines, life expectancies, and the bottom lines, the dotted lines, are the healthy life years for Belgium, France, Netherlands, Sweden, UK, and then in dark blue, the EU 27. So you can see the flat bit, it's pretty flat for the EU 27 too. And what I wanted to show there was, whereas life expectancy differences at age 65 are pretty small, the range of those countries is pretty small, and they're all going roughly in the same way. this is certainly not true for the healthy life years. Healthy life years all over the place. Now, in fact, for Spain, I know that your healthy life years do seem to be, certainly for the last 2 years, tracking life expectancy, because I looked that one up. Yeah, so you are keeping track. The difference is pretty constant, certainly over the last 2 years. But that's not true for many other countries, and it's not true for the UK. I'll give you some numbers on those shortly. Well, now actually. So if you look at the change between 2005, which is the year that most of the countries had the EU silk, there were a few countries that had a pilot in 2004 that appeared on the other slide, and 2010. I've marked here in red where the differences between life expectancy over that 5 years are less than the differences in healthy life years over that 5 years. So the countries which appear to be having a compression, and I'm looking at birth, age 65 and 85, and this table is for men. And so we're seeing a compression of disability. Activity limitation is the question for Belgium at birth. For Sweden at all ages, don't know what they're doing in Sweden, but they're doing something well. But not for any other countries. And for some countries like France and the Netherlands, there's actually been a fall in healthy life years over that period. So the healthy life years, and for the Netherlands, it was at all ages. So for the Netherlands, the healthy life years in 2010 were less than the healthy life years in 2005. For women, that wasn't true in Belgium, but it was true again for Sweden. So for men and women in Sweden, there's been a compression of disability at all ages. And so I would say, I don't expect all countries to be the same. We're all very different. We all have different health systems. We all have different emphasis on lifestyle factors as well, different prevalences of diseases. But I think Sweden's showing that there's potential there. I don't see why other countries can't do that. But we need to find out a bit more why that's the case. And we'll talk a bit more about that. To save time, I'm going to skip those two. Those two were for wider countries, Japan, the US as well. So these are the trends for the UK between around 2001 and 2010. So it's roughly a 10-year period. And in blue is life expectancy, in orange is disability-free life expectancy, and in green is healthy life expectancy. And these are the changes over the increase in years over that time period. And at birth, for men at birth, the increase in disability-free life expectancy and healthy life expectancy is greater than life expectancy. So we're seeing a compression at younger ages, and for women, not for disability, but certainly for healthy life expectancy. But after that, it's not great. And so at 65 and at 85, we're saving lives rather than reducing disability and having better quality life. And so we need to address that. And I don't think that's very different for a number of other countries as well. But the UK is not uniform, just like Europe is not uniform. And in fact, we have huge differences across Europe in terms of healthy life expectancy. So at the moment, the gap in healthy life expectancy at birth between areas in the UK is 18 years for women and 15 years for men, which is pretty horrendous. And I don't think that you can say that that is due to differences in reporting, there is a problem when you look across Europe in that some countries may have different levels of reporting of activity limitation than others. I don't think or they may understand the question differently. I don't think that's true in the same country. Okay. And the gap in life expectancy at birth is less than 10 years. So if we're looking at inequalities, health inequalities, and we're using life expectancy, which historically we have done, we are underestimating the size of those inequalities. And I was actually born in Manchester, and that's Manchester. And these ones up here are Westminster, Kensington and Chelsea, Camden, all the ones you'll have heard of in London. But Glasgow, Manchester are down here. We know some of the problems, but we don't seem to be resolving them. And in fact, those inequalities are increasing. They're not decreasing. And those inequalities are still true within even smaller areas. So in Newcastle, where I work, we have a metro, just like you do here. And Ponteland South is where our old Vice-Chancellor of our university, Provost, used to live. Okay, this is disability-free life, this is age of onset of disability. So if you like, it's disability-free life expectancy plus 55. It's age of onset of disability for a 55-year-old. So in Ponteland South, on average, the expected age of disability onset is around just under 75. In Byker, it's just under 64. Just under 64 means that onset of disability is less than pension age used to be. Okay, so people who live here are going to have to carry on working with disability. People in here aren't. So that's a brief and not very positive message for the UK as a whole. But I want to have a look at, so that's all looking at the routine measures of disability, limiting long-standing illness, the activity limitation question now that we have, and healthy life expectancy, self-rated health. I want to extend that and look at some new measures that we've got in the cognitive function and ageing study. And this is a pretty unique study. So I want to look at 4 health measures. Cognitive impairment, free life expectancy. Okay, the big question is, there seems to be more dementia. That was a question that I was asked in the interview before this. Healthy life expectancy, self-rated health. Disability-free life expectancy, but based on activities of daily living, self-report still, but rather than the activity, more global activity limitation question. And then I want to look at a new measure that we've been developing, which is a more transparent measure of care needs. Okay, so it's a measure of dependency, but it puts ADLs, IADLs, and cognitive function and incontinence into a measure where you can estimate the time that people can be left on their own, so how much care they need, intensity of care. And I want to see whether those different health expectancies produce different results for compression or expansion. So here's a cognitive function and ageing study. It was originally in 6 centres. Newcastle, Liverpool, Gwynedd, Nottingham, Ely, Oxford. But when we repeated it 20 years later, round about 2011, we had just 3 centres, Newcastle, Nottingham and Cambridge, which is Ely, Cambridgeshire. So those are the 3 that were taken forward to CFAS 2. Exactly the same design. So there were equal numbers between 65 and 74 and 75 plus. It was a stratified age sample. These were people taken from general practice. The same general practices were used for both of the studies. It included people in care homes, residential care. The only slight difference was that in CFAS 1 we had a 2-stage initial interview where we screened and then we assessed, and in CFAS 2 we had 1 screen and assessment combined, but the data that I will be showing you will just be taken from the screen anyway, so that doesn't matter. Response rates a bit different. We've done a lot with the response rates. My colleague Professor Fiona Matthews, who's a chief statistician on this study, has worked long and hard to produce weights to try and reduce the bias in those response rates. And in fact, if we just quickly think about the limitations, the response has decreased. It wasn't just because the people who didn't respond were sicker. Actually, part of it was that the people who didn't respond were too busy looking after their grandchildren to take part in a study. So there was very much an active ageing population, as well as having this problem about there being more gatekeepers for people in institutional care. We had to work a lot harder to get those. So the measures that I'm going to talk about, self-perceived health, again, the questions were exactly the same over the 2 time points. So 2 self-report, self-perceived health and disability was self-report of activities of daily living, and we used the hierarchy of IADLs, ADLs to put these together into a disability score. We did this for the first study and used it quite substantially there, and so we've kept that same measure. And then cognitive impairment was the mini mental state examination, and we used a cut point of 18, so less than 18 was cognitively impaired, 18 to 30 we've said was normal, but I've looked at various cut points and you get the same conclusions whichever you use. So just to say a little bit about the differences between 1991 CFAS 1 and 2011 CFAS 2. More men, proportion of women less, more older, so the population age 65 and over was older, greater proportion 85 plus. Because men's life expectancies increase faster than women's, more people living with a spouse. That, people might think is a good thing. In fact, at very old ages, I consider those to be a vulnerable couple because they often behave like a single person. You're not terribly sure who's caring for whom sometimes. And if something goes wrong with one, you end up with 2 people who have a problem. But the biggest change was education. Over that 20-year period, there was a huge increase in level of education in people aged 65 and over. So in 91, 3/4 of them had minimal education, generally left school at 14. That's what you did in that cohort. Whereas by 2011, only a quarter, just over a quarter, had minimal education. And that has huge consequences for a number of things. So the analysis, I used Sullivan's method to compare the health expectancies across those two time points. I used weighting to adjust for the non-response and the study design that I've said. Great strength is that it's the same design and multiple health measures. So I'm going to show you a series of slides now. And these are the change. Oh, interesting. Yes, it would be a full stop for me, but obviously your Spanish system has put a comma in. So this is change between 91 and 2011, so the extra years lived, life expectancy at age 65, healthy life expectancy at age 65, unhealthy life expectancy at age 65, men and women. And what I'll change is the measure here. So you'll get a series of graphs, all the same colours, she says, hopefully. And I've put in the confidence intervals around the healthy and unhealthy life expectancy. So healthy life expectancy, self-rated health, not quite compression, but coming close. Life expectancy's increased a bit more than healthy life expectancy. But there has been a significant increase in unhealthy years, but it's less than a year and actually only just over half a year. And in terms of the percentage of remaining life lived healthy, that went up. And so there's what we call a relative compression. So not bad, I would say, on the thermometer scale. Cognitive impairment-free life expectancy, great. Okay, we are living fewer years with cognitive impairment, particularly women. Okay, you were pleased to know. Non-significant, very slight increase in years with cognitive impairment for men, but a real reduction in years with cognitive impairment for women. Probably due as much as anything to education, those changes in education, but showing that actually the cognitive-free life expectancy was higher than the life expectancy was a great result. So a real compression there, at least for women. And if you look at, so here we can see it over across age. So I've just shown you the results for 65, but here you can see the results up to age 90. And this is cognitive impairment, and this is the with fair or poor self-rated health. And I want you to note here the years with cognitive impairment. So the green is the most recent year, the 2011, and the black is the earlier year. Okay, so you're seeing a real drop here at age 80, and even clearer here in the women. And the years with cognitive impairment are pretty constant across age. And why is that? Because cognitive impairment is a terminal condition, if you like. It happens at the end of life. Whereas here you're seeing a decrease with age in terms of, but in fact a greater proportion lived with fair or poor health by the time you get to age 80. So very good results for cognitive impairment, not so good results, but not bad for healthy life expectancy. So disability. This was definitely not a good result. Well, not if you're a woman anyway. So for men, again, life expectancy, disability-free life expectancy, you know, more than half, but only just. Almost 2 years at age 65 lived with disability. But for women, it was actually fewer years lived free of disability than there were with disability. So most of that increase in life expectancy for women were years with disability. So there's a real expansion of disability. But we had, so that was any disability, okay? Mild and moderate severe. If we look at what that was, here's your 1.9 years with disability in total and 3.1 for women. If we separate that into years with mild disability and years with moderate severe disability, you can see that the majority of it was mild disability. So it's an expansion of mild disability. There is a significant increase in moderate severe, but it's about half a year. And so the majority of that increase in disability is years with mild disability. So, in summary, life expectancy has increased, years free of cognitive impairment have increased, real compression there, relative compression for healthy life expectancy, but expansion of mild disability for disability. And so my conclusion from that is one measure isn't enough. We can't just say that, oh yes, these extra years are healthy ones, compression. It depends on what measure of health that you're looking at as to whether or not you're going to get a compression or expansion. And it may in fact be dependent upon which age group you look at as well. We saw that from the earlier ones. And so we haven't really so much looked at partial health expectancies, reported those. Maybe we have to start doing that, where, you know, we look over age groups, you know, and we do the younger old and the older old separately. In terms of comparisons with other countries, for healthy life expectancy, the Belgian increase was similar in healthy life expectancy, was again similar to the life expectancy. It's only really Denmark that seems to have been out of step with the results that we found. Belgium, France, the USA, their paper came just after our paper, and the Friedman paper, and it was really interesting to see how similar it was, because their moderate disability was more like our mild disability actually, and so they saw an increase in moderate rather than severe, and France has seen an increase in mild mobility disability too. So there is some consensus there across other countries, apart from Denmark, and maybe Denmark and Sweden are different. Well, they are different. They certainly have a lot less obesity than we do, and they're probably more physically active than we are too. But their health systems are different too. So the fourth measure that I've been looking at is based on a very old paper by a geriatrician called Bernard Isaacs in 1975, which is a scarily long time ago. And it basically uses ADLs, IADLs, incontinence, cognitive impairment, to put people into categories of how much care you think they would need based on the fact that they require help with that activity. So if they can't get to the toilet without help, or they're often incontinent and need help dressing, or they have severe cognitive impairment, so that's a mini-mental state of less than 10, so that is really severe cognitive impairment, then these people probably shouldn't be on their own for more than a few minutes. So they're classed as requiring 24-hour care. Medium care is requiring help at regular times daily. So we've used various ways of defining that, but in CFAS we've got need help preparing a meal or dressing. Sometimes we've used medication, needs help with medication. So you can do that at set times each day. You don't need to be there all the time. Low tends to be requires help with instrumental activities of daily living, things like shopping, bathing. So that requires help less than daily. And then I work this way, so I define people with the highest level first, and then whoever's left over, if they've got no missing data, are independent. And I've looked at that against other variables, and it seems to work out okay. So same sort of graph as we used for the other one, same life expectancies, obviously. And these are the changes over that 20-year period in independent, low-level dependency, medium, and high, with the confidence intervals. And again, this plays out very similar to the disability, actually, so that the cognitive impairment isn't resolving it all, if you like. The positive cognitive impairment for women is not actually playing out by making them totally not dependent or anything. So there's been an increase in low-level dependency. Most of that increase in life years is years with low-level dependency. For men, it's about equal between independence and low-level dependency. So men are coming off slightly better than women, and we can talk about that when I come to the other MODEM modelling. But one of the other things that we found from this study was that actually people with the same level of care in 91 and 2011 were much less likely to be in a care home in 2011. So in between that time, we had something called Community Care Act in the UK, where we tried to provide care at home rather than putting people into residential care. And the result of that is that there's a lot more dependency being cared for in the community, and that has a knock-on effect for carers, because we don't provide 24-hour care like it should be provided. We don't, frankly, have the money at the moment. There's a big debate going on, and there's a government green paper about to come out about funding for social care. But for instance, at 85, for 85-year-olds in CFAS 1, 74% of them with high dependency were in a care home. It was less than 50% by 2011. So that's a lot of people, very dependent people, who are now in the community and being cared for, maybe by formal services, but almost certainly by family as well. And then just thinking about the ADLs and IADLs, I actually did a quick analysis of comparing 2011 to 1991 and the prevalence, okay, the change in prevalence of individual items. So this is adjusted for age and sex and centre and education. So for instance, the odds ratio, so the odds of requiring help with bathing was actually, if it's below the line, it was actually less in 2011 than it was in 91. If it was above here, it was greater in 2011 than it was in 91. So most of these have got worse. So it's not just a single item that's producing those results, okay? It's that people have become more dependent in many of these items. There's two where there's been improvement. Preparing a hot meal and bathing. Why do you think those two have shown an improvement in terms of the odds of people requiring help is less now than it was before? Families? No. I'm surmising here, actually. It could be a bit of that. No. We shower a lot more. Showers in 91, probably in British homes, there weren't that many. People had to get in and out of a bath, and that's tricky if you're disabled. Hot meal, microwaves. Okay, so there's been technology or environmental changes that have contributed to some of that. But even those were not enough to offset the others. But maybe technology could be used for some of the other things as well, better than they are doing at the moment. And then I put this slide up to how long do older people require care now. So the 2011 results, you only saw the change between 91 and 2011. So for a person aged 65, a man will spend about 11 years independent, 4 years requiring care, less than daily, and then about a year each requiring care daily or 24-hour care. So actually, there's, when you look at the whole of it, there's not a huge amount here. And we have to start planning for that, okay? So I'll mention that towards the end, that we need to be getting our results out in ways that people can use them, okay? And showing time spent in states are one thing, particularly for actuaries who might be trying to estimate products, long-term care products. So finally, what does the future hold? Get my crystal ball out. And I want to say something because of long pop and so most of what I've shown you at the moment is cross-sectional. So I've been developing a micro-simulation model, which we've called PACSIM, Population Ageing and Care Simulation, which is part of the MODEM project. So the MODEM project is focused on dementia, but I was very keen that our epidemiological model included more than dementia, not least because treatment of dementia and interventions for dementia might not be possible if people have other comorbidity. So I wanted to include other diseases as well. And actually, I was quite interested to know how they played out over time too. So I personally don't just have a focus on dementia. So what it was, so the main outcome is dependency, this interval of need measure. So to look at the health and associated care needs of the English population from 2014 for the next 30 years, actually. And it was a heroic data job, thanks to my colleague, Dr. Kingston. We put together the 3 major ageing studies in the UK, longitudinal studies. The cognitive function and ageing study I've already told you about. ELSA, the English longitudinal study of ageing, you'll know because it's a sister study to SHARE, which Spain is part of. And then, so they're 50 and over, they're 65 and over. Understanding Society is the old British Household Panel study, is the new British Household Panel study. So it's adults 16 and over. But in fact, at the moment, we're including people aged 35 and over. Why are we including people aged 35 and over? It's so that we can get a picture over the next 30 years of people aged 65 and over. Okay? So those 35 and overs are aging in to the older population over the next 30 years. Oops, wrong one. So survival comes out of the Office for National Statistics population projections. So that's the projections bit. But what we do is we use the longitudinal, I'll show you in a minute, we use the longitudinal data to reproduce or age people with these particular characteristics. So we've got age, sex, education, marital status, occupation, we've got smoking, physical activity and BMI, and then we've got effectively 12 diseases. And we've harmonised the data across those 3 studies, which was no mean feat. And then the outcome, well, actually, some of the diseases are outcomes, really. But the thing we're really interested in is care needs, so that we've got dependency as well. So how do we do this? By a very complicated set of SAS macros, basically. So we combine the variables from the 3 studies. We calculate from the 2-year gap between 2 waves of the studies. We calculate the transition probabilities for each of the variables. We weight up the base data set to the national population, and we produce a starting, and we then take a 1% sample because that's too big. And we end up with a starting population of about 300,000 people. And then what we do is we basically apply those transition probabilities by month and calculate the probability and take a random number and say, does this event happen or not, depending on whether or not it's bigger or less than the random number. And then update the status if it's changed. So we basically artificially age people through this simulation model. And we can apply, I'm in the process of doing this now, we can apply scenarios, so we can change the probabilities of these events. We can say what happens if the probability of going from normal cognitive function to mild cognitive impairment reduces, halves, reduces by a quarter. What happens to dependency? So we've on the website, on the Modem website, there's a technical report if any of you are interested, and you can see how you can see what variables affect what other variables, basically. So what do we get? Well, if I'm just going to concentrate on not on the dependency, as I said, because I can't show you those results. But in terms of disease prevalence, so the blue line is the disease prevalence in 2015, and the red is in 2035. So this is like the next 20 years, almost to the last 20 from CFAS. And we see a rise in prevalence of most of those conditions, apart from depression, which is pretty low anyway. There's possibly a question mark about its depressive symptoms, really. That was less good a match between the studies. These ones were all self-report using exactly the same question. Dementia we had to fiddle about with. That's produced from cognitive impairment and education and age. That's simulated almost outside the simulation. But again, the prevalences look very consistent with other studies in terms of the prevalence of these conditions. The Health Survey for England we used to match them up with. So, the big question is, those were individual diseases. What about multiple diseases? So these are the years lived with multimorbidity. So that's no diseases at all. Of that list of diseases, we just add up how many they've got at any time, and then characterise them as no disease 1, 2, 3, 4 plus, and then apply Sullivan method to each of the years, basically, with those prevalences. And what you get is that there's going to be a bigger rise in numbers of, in the years lived with 4 or more diseases, and in fact with 2 or more diseases. I'll show you that there. So these are the total life year changes between 2015 and 2035, and that for men, about 3.5 years, and that's made up of, well, there's going to be a bigger gain in years lived with 2 or more diseases, and that's currently how multimorbidity is defined. But if you separate that out, it's years lived with 4 or more diseases, which will increase the most. And what's driving that? Obesity, pretty well, physical inactivity, are driving many of those conditions. And that's why I was interested in putting in the multiple conditions, because the same risk factors affect many of those conditions. So the dependency-free life expectancy results hit the press in a big way. We also did some projections of if the prevalence of dependency remains the same, what will that mean for the number of care home places? That was all they wanted to know. I kept telling them, but the good news is that the rise in dependency is low-level dependency. They didn't want to know that. They wanted the bad news, which was more care home places needed. And then with the multimorbidity paper, again, you know, we got the front page of the Times. This isn't us. I hasten to add, this is us. Lazy lifestyles to cause surge in serious illness. And we made the Guardian as well, but we made the front page of the Times. So my conclusions are that health expectancies are important indicators, but it's important to utilise multiple measures. Okay, so I've said all of that before, but I think in terms of future, we need to think of how we present health expectancies to policymakers. But it's not great, and we need to make sure that they understand what we're saying. And so we need to find innovative ways of presenting what we're doing and getting them out to people where it's going to make a difference. And so that was my push for visually presenting the years lived in different care states, because that's something people can engage with. If you know that, you know, at age 65, you've got to plan for, if you're a woman, about 2 years where you're going to need 24-hour care. You're going to you know, and that's obviously going to come at the end of your life. So you need to think about that and plan for it. Obviously, the other things like more comparative trends again across countries, we're moving towards that, but we're moving pretty slowly towards it. So I've put some references on the slides as well for you to these papers. The bottom 3 you may or may not already know, but you may not have the government office one. And then I'd just like to acknowledge the help of all my colleagues, particularly Andrew Kingston, who's helped me produce the MODEM model, and CPAR, the Australian Centre of Excellence, because it was modelled on an Australian simulation model, and so we were lucky enough to be able to go over there and collaborate with them too. And thank you.